the recent things that we're all talking about. For instance, there's a paper that has been retracted. It's been shared widely in our community about the false positive rate. This false positive rate was about China anyway. There's a lot of people sharing it, specifically implying that there's a huge false positive rate from testing, as if that is relevant to the United States. The Chinese had a different test that they used, and now this paper's retracted. So that kind of is going to leave most people's heads spinning. Also there's this issue of this Imperial College of London fellow who came out with updated predictions. And I'm an expert in dynamic systems modeling, among other things. I don't know everything, but I do know dynamic systems modeling. It's something that you learn in ecology. It led to chaos theory. It's a very interesting field, but the projections that are made by epidemiologists are difficult to track, and difficult, I think, for the public to understand exactly what they mean and what their significance is, and how to interpret some of what they're saying. And so what I thought I would do today is slow this way down and bring you a couple of examples of modeling that are based on things that we can understand, that don't have the entire fate of the world in line. And so I prepared a small presentation for you, and I'm going to show you some of the sensitivities in this setting when you're trying to model whole population outcome on the basis of multiple variables that are all changing. What I want to do is model those things for you so you can see how to think about it, how to interpret it, and I hope this helps. So where's my slides? I want to go to, I may have to still add them. Let's see. I've also loaded up the video of the modeler. I thought I added the slides. Apparently, let me bring these slides into here, PowerPoint. And sorry about this, folks. I'm very sorry about this. We'll have it in a moment. Okay. Okay, here we are. So this is Dynamic Systems Modeling 101, COVID-19 models and ice cream melting. We're going to first talk about ice cream melting. I thought that, looking at this from a perspective of things where not everything is on the line, there's no politics involved, breaking this down into something so that more people have a better chance of being able to be conversant about dynamic systems modeling. I'm not going to guarantee that you're going to be an expert in this by the time that we're done, but I've hoped that I've broken it down for you in simple terms that are not overly simplistic, so that you can transfer that knowledge into your discussions about what it is when the epidemiologic models are being discussed. And so the problem here is that public health officials and elected officials are totally dependent on models that are being made with incomplete data. And as time goes, we're in uncharted territory here with respect to this. As time progresses, new information is added to dynamic models. That makes them dynamic models in part. The other thing that makes them dynamic models is that the actual parts of the model actually interact with each other and change the direction of their impacts on outcomes. And this new information can include new parameters and new parameter models. I'll define what these are, and new ways that the different parameters can interact. So a parameter is something that we are trying to say is something that we measured, and we're trying to get an estimate of it, and then use that estimate of it in some way, maybe to make a prediction or maybe to interpret a prediction. And in dynamic modeling and other kinds of modeling, very simple linear modeling, we have parameters that we think that we understand fairly well, and that could be very straightforward. So let me give you a very simple example. If you're working in a factory, and you're doing quality control in a factory, and you're making boxes for crackers, the specifications of the operations of the machines have to fit within a particular set of parameters, and those parameters will then allow the box to fold properly. And if you don't have the machine set right, or if there's a flaw in the machine or a flaw in the design of the machine, then there'll be an alarm that goes off because the particular parameter is off, and then you might be able to adjust it. You adjusting that to make the boxes be created right, the cardboard being cut properly, is a dynamic process. And so you have changed not the model, but you've changed reality, and then now you have new inputs that go into the model, and then the parameter estimate updates. Does that make sense? And so I'm going to break this down for you a little bit more, but there's new parameters that come, new information comes into play, and by its very nature, dynamic modeling outcomes yield predictions that will change as a result of changes in reality. And the changes in these predictions, importantly, do not mean that a modeler admitted that he or she was wrong. And I want to set this straight to try to help us come to terms with what we can have confidence in and what we can't have confidence in, coming from places like Imperial College of London, coming from places like the Daily Beast. It's very important that we have, as a community, we remember to not use the media outlets and not cite professionals who have lambasted people for being vaccine risk aware in the past. Like all of a sudden they're good actors. We have to avoid falling into the trap of something that happens to fit something that we desire, something that we hope is true. I really, really wish the Imperial College of London's predictions were updated and it was okay to shut down, the lockdown and reverse the lockdown. In all of my heart, I really honestly wish that. And of course, everyone, I believe, does, except for some people that might be benefiting from it. We're not going to go into that right now. But let's go back to the slides here. So, so let's talk about ice cream melting, and then we're going to talk about early COVID-19 interventions. I'm not going to model late phase or model because it's irrelevant to the point, because we're still early in this, believe it or not. But in the ice cream melting analogy, imagine that I'm a modeler and I want to know how many ice cream cones that are left out in the Arizona sun will be melted at a given time. All right. This idea came to me after reading a news report where somebody was asking about the rate at which ice cream melts, and they said, okay, well, we really don't know. And so they took a double scoop ice cream out into a parking lot. I think the temperature was incredibly high, like 124 degrees. And so all the data that I know of in the world are as follows. The news report said that at 124 degrees in the parking lot in the afternoon, a double scoop ice cream cone of a certain brand of a certain flavor in a waffle cone takes 39 minutes and 20 seconds to melt completely. And that's all the data that we have. So there's a lot of missing data here. We don't know. People eat many different kinds of brands of ice cream. They might melt differently. There's different flavors of ice cream that might melt differently. There's different shapes and textures of cones. And some eat one scoop, some people eat 2 scoops, and some people eat 3. But nevertheless, my job is to try to understand the dynamics of ice cream modeling, and I have 2 data points. And see, the problem right there is that that's basically where we're at when we're in the exponential phase of a COVID-19 outbreak or another exponentially increasing function. We have basically 2 data points, and we're trying to predict thousands in the future. And might as well only be 2 data points. And this is what the data look like. On the x-axis, that's the horizontal axis, we have the number of minutes since we put the ice cream cone out into the parking lot. And on the y-axis, we have the percentage of ice cream cones that are melted. I'm going to use percentages because it's just, we're trying to remind us that we're doing a projection model. We're trying to predict, in general, how long does it take for an ice cream cone to melt out there. Now, if I create a model, which is percent melted is equal to minute that I'm interested in, times 1 over 39, because I know it takes 39 minutes, multiplied by 100, that model is a linear model, and it will perfectly predict minute by minute exactly, just from 2 data points. It's very straightforward. But there's a big assumption here. Okay. Well, first of all, before I get to the assumption, the input, what I call an input variable, is x. That's the x-axis, and that's time. and that should be labeled on this. I'm sorry it's not. I threw this together quickly. The parameter that I'm using as a correction is 1 over x, whatever how long it took, because I know that that's going to linearly increase. And the constant that I'm using is simply to bring it to a percentage, because otherwise it would be a decimal. But I can predict a percent expected to be melted at any time by just inputting the time and using this equation that I have up at the top there. The percent melted is equal to whatever minute you're at times 1 over 39 times 100. And that equation will give me the percent expected to be melted at any time. And it's important to understand that this particular model is an interpolative model. It's interpreting inside the 2 data points. I'm not extrapolating to future time beyond 100%. That's a reality. But it's also relevant for this type of ice cream. But I'm making a huge assumption, and so on. I'm making a huge assumption here. The huge assumption that I'm making is that this is, in fact, a linear relationship, okay? And it may not be. This linear relationship is a major assumption because I only have 2 data points. We need more information. All those factors that we talked about earlier, they might cause the relationship to be nonlinear, such as the mass of the ice cream cone or the time of day, and the temperature itself changes over the course of the day. So melting might speed up or slow down depending on whether the temperature is increasing or decreasing. So that's why we call it dynamic systems modeling. So actually given 2 data points to fit the 100% melted at 39-20 seconds observation, any nonlinear model could be specified and it would fit as well. We only have 2 data points. But remember, this is just a toy exercise for education. There's not a lot on the line. We're talking about ice cream in parking lots. But nevertheless, if you really care about ice cream in parking lots here, the x-axis being minutes and time, I created a nonlinear model here that also explains 100%. It predicts 100%, and then I interpolated again. So here we have a nonlinear that's just as good as the linear to getting to that data point. And I'm just using this example so far to help you understand some of the terminology. See, that's a nonlinear relationship. So let's pretend now that all I had were data for the first 10 seconds. Okay, let's say that I actually had data, and it was now a percentage of ice creams, let's say, that were melted. I'm changing the toy scenario a little bit just to make it more applicable to COVID-19. But let's say that we only have data for 10 seconds, and it's a really super hot day, or it's in the oven, or something else, and it's in the parking lot. I want to keep it in the parking lot. And we can see that we're going to now say that 7% of the ice cream is melted. Okay, so our data will look like this. We can say 7% of the ice cream cone is melted, okay? Our data would look like this. It's nonlinear. We're going to keep the nonlinear for no particular reason other than it more similarly represents the increase in spread of infectious disease in a population. But now I'm going to extrapolate because under extrapolation, I'm going to create a model. And the first model is I'm not going to do anything. I'm going to let the cones out there. I'm going to bring 100,000 cones into the parking lot, and I'm just going to let them sit there at 120 degrees. And from my model, I'm going to tell you what percentage of these ice cream cones are likely to be melted after 39 minutes and 22 seconds. All of the data points after the 10-second in this situation are, 1, dependent on the model, 2, they're predicted given the current situation, and 3, they're dependent dynamically on anything that might change. So here's what this looks like if we have interpolated, observational data here. These are measurements taken in our study, and these are empirical, I should say, not observational, but empirical data. And it gives the same expected output as my overall linear model because from earlier, because it's a toy situation and I know the data perfectly. But let's pretend that I only have these first 10 seconds. Now my job is to make the rest of this prediction, and I use that with an equation like I showed you before for the linear situation. And pretty much within a range of confidence, I can say that this is probably what's going to happen to the 100,000 ice cream cones. But and that 100% will be melted by 39, 40 minutes or so. And that's going to be within a fairly accurate range, I would expect, at 120 degrees, just based on that one observation. Okay, assuming that my linear or nonlinear model is correct, I will also be correct every step along the way. But that's a different problem, and we're not going to talk about that particular characteristic of a model. Now, there's going to be a new parameter added. This is a dynamic situation, and somebody says, I like ice cream. I'm going to bring huge freezers to the parking lot. I'm going to save these ice cream cones. But I only have space for 50% of your ice cream. So as a result of the prediction, they bring in 100 freezers, and they can only save a half of the cones. So there's a new parameter that's been added. This new parameter, this new model, is that we're putting ice cream cones into a freezer. And this new parameter is important because we don't expect ice cream in freezers to melt. Now, what would that look like? That would now change the shape of the curve and the shape of our prediction completely. It would cause us to change and update our model and say, wait a minute, yeah, up until we get to 50% melted, those are still melting, but the 50% that we put in the freezer will not melt. And so now that flattens off. That's the nature of real-time dynamic prediction modeling, and it's difficult to do because now, what if I then took the ice cream cones back out of the freezer and I shut down the freeze the ice cream freezer program and I reversed that? Then we could go back to a situation where it increases again. Okay, so understand that what's happened in the COVID-19 situation here in the UK is that this Dr. Ferguson from the Imperial College, he made a prediction initially where it was the do nothing model. This is what's going to happen if we do nothing. And then he modeled at the same time back then, he modeled what would happen if we did some type of intervention, some kind of isolation program, right? And he had data that was based on the current situation at the time. He also had data from the National Health Service that said, this is our intensive care unit capacity. We can only handle so many. And then it turns out that his prediction was that they were going to be short by 8 times. Eight for every one patient that needed a bed predicted, they were going to be short 8. Okay, like I said, 1 out of 8 would get a bed. Let's say that, okay? Now, as time went on, because he did the modeling, because people were seeing the increases in the infection rate, and he mentions that as well, there's an actual increase in the infection rate in that over time it looks like it's more infectious in the UK than they originally presumed. And then because the UK listened to their model, to the modeling, they enhanced their capacity for intensive care units, and they got more ventilators, and they're still getting more ventilators, and they're catching up. And now he says that due to the increased infection rate, there's a change in the model, and due to and I hope I have that right. I hope I don't have that reversed, and I apologize if I do. But due to the increased infection rate and due to the increased capacity, he has now improved, and importantly, due to the fact that they started isolating, he now has some revised estimates. Now, I've listened to his video, and I'm going to play the video for you at the end, and hopefully that will help everybody understand what he's saying. It's very difficult to follow, I'll give you that much. But this morning, he actually tweeted something that I think is fairly devastating, and people are experiencing psychological distress and trauma. They're experiencing intellectual whiplash. What do I think? What do I trust? I don't know where I stand. Okay, and people who are conspiracy prone will say that this is just another move on the chessboard for them to now reverse course. But let me read this to you. This is from Ferguson yesterday. I think it would be helpful if I cleared up some confusion that has emerged in recent days. Some have interpreted my evidence to a UK parliamentary committee as indicating that we have substantially revised our assessments of the potential mortality impact of COVID-19, Ferguson said in a Twitter thread posted Thursday. This is not the case. Indeed, if anything, our latest estimates suggest that the virus is slightly more transmissible than we previously thought. Our lethality estimates remain unchanged, he continued. My evidence to Parliament referred to the deaths we assess might occur in the UK in the presence of the very intensive social distancing and other public health interventions now in place, Ferguson said. See how he's communicating? This is terrible, terrible, terrible communication. What he just said, and let me interpret this for you. He said, when I spoke to Parliament, I said that the deaths that we can expect to occur in the UK, now that we are social distancing, and now that we have other public health interventions in place, are now updated, and we expect a lower revised estimate. Without those controls, however, his initial do-nothing model assessment remains that the UK would see the scale of deaths reported in our study, namely up to approximately 500,000. So this is an opportunity to take a deep breath. I know that this is going to be very distressing to people. This you're hearing this right now for the first time. This is way more than an academic exercise. These are people. These are medical, facilities that are in fact, being overwhelmed. I live next to a person. I'm not going to say who they are or where they work, but this person moved in, I think about 3 years ago, and I've seen her exactly twice. Now she's home and she's quarantined because she was in contact with someone. There's somebody I know that works at a Chrysler plant up in Detroit, and they had somebody show up at work. That person is now self-quarantined, and that person, who was, for all I know, a middle-aged person, has died. Okay, the person that's quarantined was in contact, but he's died. Yeah, that's what I'm saying. So, and so, this shit is real. I mean, there's way too much over-intellectualizing here in terms of communicating to the public, and I hope that I can at least give people a framework in which they can understand that when modelers do modeling and they update the parameters or they get new information, it's not that they're admitting that they're wrong, and I want to set that straight. But let's look at this. I did modeling. like this. Oh, there's some feedback. I did modeling some time ago in February using a very simple model in the early stages, and the parameters that I have here are the basic rate of reproduction here. Okay, there's the case fatality rate, which I'm assuming is 2%. It turns out it's not that important what it actually is. There's the degree of social isolation and the natural recovery rate of 80%, let's say. It could be much better, and we'll actually change these in real time. But there's something I want to show you in terms of the combined effects of successful treatment and social isolation lead to some very, very different outcomes, predicted outcomes. Here we have time since the first outbreak in the United States, let's say, and here we have the total number. This number is huge, 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 because this is a do-nothing model. Okay, so actually this model is an underspecified model. It should be a S-shaped curve. I did not model in the effects of the slowdown that happens when a lot of people get infected, because this is for early, or just early in the outbreak. Now, that doesn't mean the model is wrong. It's right for early in the outbreak, but it's wrong for the whole time period. But I just want, and again, like I said the first time I did this, I'm not trying to actually model the outbreak. What I'm trying to do is demonstrate the importance of understanding that these prediction models are very sensitive. Something's happening. I'm sorry that that's happening to this. I'm going to try to pull out. Maybe it'll have something more to focus on. Something's happening with this. Sorry about the pulsing there. I don't really understand it. Maybe if I pull out some more. Okay, so well, all I'm going to do is I'm going to increase social isolation to 10%. With increased social isolation, you see that the curve changes, right? And I'm going to do just 25% social isolation. Major difference between 10% and 25%. A huge difference in this very simple toy model. How about just 15%? It still increases at 15%. 18%. Now we go from more like a 18% gives us more like South Korea, and that's what can happen with testing. Okay, but look at the major difference if we go from 0.15% to 0.18%. Okay, in terms of the numbers outcome, we got 30,000 infected in a year and 500 infected in a year. Just 18% social isolation, folks. Now, that is, again, a toy model. I don't want to stand behind any of these predictions, and please don't take these as in any way real predictions. But the problem is it's still increasing, even with this little bit of and we have a natural recovery rate that might be low. So let's go back to zero social isolation, the do nothing model, and let's bring the natural recovery rate up to 95%. We still have a huge number of cases that happens, okay, just natural recovery with no, morbidity that we don't know about. But the difference between 95% and 94% is huge. It goes from 20,000 to 90,000. And that's because this is an exponential model, all right? So just 0.93, now we're up to 400,000. That 0.1% of natural recovery is huge, okay? So the nature of these models, because we're modeling in an exponential curve, they're going to be very, very different from day to day, depending on what we do. So let's bring in 10% social isolation, and let's bring in 10% successful treatment. Now we have a very small number of cases, and we've bent the curve. So, and then of course, if we bring in natural recovery, which I really don't think we have good data on, then we're just down to tens of cases. That's with a 2% case fatality rate, which I don't, these parameter estimates all over the place. I think I've made my point. It really depends on what the reality is about what's going on, not what a person, believes is real at a given time. And I don't know how to say that any other way than, there's a serious problem. I'm going to have to jump to the video now because I have a radio interview coming up at 10:30, and Bernadette, if you're watching, I'll be with you very shortly. I'm looking forward to that. I want to try to find the part of the video here where he actually said what he said. I'll let you guys listen to it.
Saying to all of our witnesses today and those
it's about
put on record our gratitude to the wider science and research
it's like
community.
Is this it here? Yeah, that's him.
We're struggling a bit with the feed, Professor Ferguson. But we can still see you. So just repeat that last bit again, if you wouldn't mind.
Apologies.
No,
so
not your fault.
The revision was that basically estimates of the proportion of patients requiring invasive ventilation, mechanical ventilation, which can only be done on a critical care unit, roughly doubled. And so the combination of that and NHS England assessing how much they could surge led us to conclude that there would be no way that even with what we're now talking about, surging at least double normal capacity, if not triple, would be still insufficient to cope with an epidemic which was just mitigated, where we weren't going for full-scale lockdown and containment.
Thank you. I understand that, and indeed the peak, according to your paper, is that the peak would be 30 times the maximum capacity of the ICUs across the country. I think I'm right in saying.
So that would be an unmitigated. I think I don't have the paper in front of me. I think we concluded it was about 8 times
right.
in the sort of mitigated single peak epidemic, the best we could do. I should say that with what NHS are now planning to put in place, that gap reduces from 8-fold up to I think about 3-fold, but it's still a 3-fold gap.
So on the basis of the announcements that the Prime Minister made this week, you think that gap at the peak is about 3-fold?
No. I mean, so let me go back and be clear. So NHS, since we did that initial analysis, which came out on the 16th of March, NHS have refined their ICU surge capacity estimates. Those have gone up again, more than doubled. And and that means the gap, had we followed the mitigation strategy, would have been less, but it would have still overwhelmed ICUs.
I understand. And have you...
In this current strategy being adopted now, we think that in some areas of the country, ICUs will get very close to capacity, but that it won't be significantly, it won't be reached at a national level.
So that's a very important point. And that is a combination of the surge in the NHS provision, plus the measures that the government announced this week, that will at a national level, on your modelling, be containable within the capacity of the health system.
Yes, there will be some areas of the country which are extremely stressed, but we are reasonably confident, is all we can be at the current time, that at a national level we'll be within capacity.
Thank you. That would be tremendously reassuring to many people, although we do understand your caveats that this is based on predicting something that hasn't happened yet. Just a couple more points, then I'll turn.
Okay, so we're going to leave that there, in part because I have to go to the radio. But here's what I want to end with for all of you to do. Here's the action items that I'd like to suggest. First, go back to my blog article from 3/15. This is a couple of weeks ago, how the COVID-19 pandemic will end, right? Here, I go over some of these models and the parameter estimates and so on, understanding this is a toy estimate. Read that article, and here's what we need to do. In my opinion, the worst possible outcome here is a pandemic that kills 20,000, 250,000, a million. That's the worst possible outcome. And to have our community be seen to be impeding the fight against COVID-19. Why? Because not only will there be a hammer that falls in terms of a vaccine mandate for what we think is likely to be an unsafe vaccine, and I'm working on that front as well to try to communicate to the vaccine manufacturers, if you do make a vaccine, don't include these epitopes. That's all been communicated. They'll also outlaw the freedom of speech. We'll lose our ability to speak. And you can see that this is not a time for pointing fingers. This is not a time for anything other than updates on reality. This is a dynamic, fast-changing situation. And I encourage all of you to take this seriously. I encourage you to stop talking about 5G simply because it takes up bandwidth that could be more valuable speaking about other things. Because I would encourage you to stop thinking that because it's mostly 80-year-olds and smokers and people with chronic illnesses, our community has talked forever and ever and ever about 54% of children have chronic illness. A huge look at the rate of diabetes. If there's a 6% case fatality rate, and that's an if, 6% case fatality rate in people with diabetics, and 45% of Americans have metabolic disease, we are a sitting duck unless we do the right thing. What that right thing is, we could debate all day long, okay? But the virus came into a virgin soil population, and if you fit the profile of somebody who is absolutely not at the highest risk, good, great, wonderful, fantastic. We can end this by a combination of social isolation and treatments, because I have very low confidence and faith that there's going to be a safe vaccine.